In this session, we will discuss a case of acute bronchiolitis. Acute bronchiolitis is a relatively common condition which affects infants and very young children, usually below the age of 1 year and not after the age of 2 years. It is actually a viral lower respiratory tract infection, and it causes bronchiolar obstruction due to inflammatory edema, mucus secretions and cellular debris. And as you know, when the small airways are obstructed, that will lead on to wheezing. So wheezing is the hallmark of acute bronchiolitis. Respiratory syncytial virus is said to be the common cause of acute bronchiolitis, which can infect children of any age, but it manifests as acute bronchiolitis only in infants. Why only in infants? One thing is, the small airways are very narrow in infants. So you know, in small infants the cross-sectional area of bronchiole will maybe this much, whereas in older children it may be this much. So you know, the airway resistance is inversely related to the fourth power of radius. So if the radius is reduced by a small margin, the resistance increases to a significant extent. So even otherwise in infants the small airway resistance is high, and a small decrease in the radius of the airways because of this inflammation or mucus or debris that increases the airway resistance markedly. Again, the airways are more collapsible in infants compared to older children and adults, and that collapse is more in expiration. So when the airways are collapsed in expiration, that leads on to expiratory wheezing. Also it leads on to air trapping. The air will enter the alveoli during inspiration, but during expiration, because of the collapse of the small airways, there will be air trapping. This will lead on to lung hyperinflation, and sometimes the small airways are completely occluded, which leads on to patchy atelectasis or collapsed areas, and all this leads on to hypoxemia and hypercapnia, and this is due to the ventilation perfusion mismatch. The ventilated parts of the lung may not be perfused well, or the perfused parts of the lung may not be ventilated well. That will lead on to hypoxemia. As already mentioned, respiratory syncytial virus is the commonest cause of acute bronchiolitis. More than 50% of cases are due to RSV, and in our area it usually peaks in certain months like August and September. We see a lot of infants getting admitted in various hospitals in August and September months most probably due to RSV infection. Other viruses like parainfluenza, influenza, adenovirus, rhinovirus, all these can cause acute bronchiolitis. And the factors affecting severity of bronchiolitis: all infants who get infected with RSV may not develop the clinical picture of acute bronchiolitis, and the manifestations depend on certain factors like younger age. The smaller the infants, the manifestations can be more, and male sex, usually male children are more severely affected than females. Those exposed to passive smoking, they are more severely affected. Breastfeeding offers significant protection for the development of acute bronchiolitis. Preterm babies are severely affected if they get infected, and those babies having congenital heart disease, those having chronic lung conditions or certain immunodeficiency situations, all these groups are severely affected due to acute bronchiolitis. The clinical manifestations are initially the upper respiratory symptoms like running nose. That is the initial symptom, and there may be low grade fever, and there will be cough. After 1 or 2 days, there will be cough, which can be paroxysmal also. Paroxysmal cough means the child goes on coughing without taking breath in between, which very frequently we observe in pertussis. In bronchiolitis also there can be paroxysmal cough. And later the baby develops dyspnea, tachypnea and irritability. And in very small babies, preterm babies and all, it can lead on to apnea also. And as already mentioned, the more airway resistance is during expiration, the duration of expiration is increased. When you observe the baby, you can see that the baby takes more time to breathe out. And there will be nasal flaring and chest retractions. And in severe cases, there will be cyanosis. And as in asthma, we discuss about silent chest. In bronchiolitis also, silent chest with a severe, the baby appearing very sick and chest is silent, that leads on, that means the condition is severe. Drowsiness, these are the symptoms or situations in severe illness. And diagnostic evaluation, as already mentioned, acute bronchiolitis is a clinical diagnosis with a typical clinical picture, and routine X-ray is not needed. In X-ray, what you can observe is hyperinflation. And in most of the cases, there will be patchy atelectasis also. And this atelectatic picture may get confused with that of pneumonic patches. So very often the X-rays can mislead you. Complete blood count also is not very helpful. Viral testing like polymerase chain reaction, which we do in case of COVID and all, such tests can be useful but not routinely done. And you can do various tests to assess the severity of the condition and to rule out other conditions. And regarding the treatment, the mainstay of treatment is supportive care. Mild cases may not require hospitalization, but severe cases needs hospitalization. And the most important intervention done is providing humidified oxygen. We target a SpO2 value of 90. And the babies need to be hydrated well. That means the babies who can breastfeed, they continue to breastfeed. If not feeding well, they need to give fluids through a nasogastric tube, or sometimes parenteral IV fluids may be needed. If the baby gets dehydrated, the secretions becomes dried up and the airway obstruction will become more severe. And suctioning of the nares and oropharynx is another important intervention we can do. There is no definite role for any of the pharmacological interventions like nebulized salbutamol, nebulized steroids, nebulized hypertonic saline, nebulized epinephrine, ribavirin, which is an antiviral drug. None of these offer a definite improvement in the clinical situation. So there is no definite role for any drug management. And the complications in severe cases, especially in preterm babies and all, they can develop respiratory arrest or respiratory failure, dehydration, electrolyte imbalance. Some of the babies develop otitis media due to the virus itself. Secondary bacterial infection is possible but said to be rare. And regarding prevention of bronchiolitis, hand hygiene as we do for COVID appropriate behavior, avoiding overcrowding, avoiding passive smoking, and another drug, palivizumab, intramuscularly in high risk cases, which is very costly, effective only against respiratory syncytial virus, not frequently given. So these are some details about acute bronchiolitis. We will move to a case. So a 5-month-old baby, male child, with a birth weight of 2.25 kilogram. 2.25 is on the lower side, low birth weight. Is presented with cough for 5 days, fever 5 days, and breathing difficulty 2 days. The history of present illness, the baby was apparently normal till 5 days back and developed running nose with the cough which was non-paroxysmal, no diurnal variation, that means there is no significant difference during daytime and night hours, and there is no post-stressive vomiting. Cough is not disturbing the sleep or feeding. And the fever started on the same day evening, which was low grade, continuous, not associated with rigor, and subsiding with the paracetamol. No history of any rash. And there is history of vaccination taken 3 days prior to the onset of symptoms, that is third dose of pentavalent vaccine. So when the baby develops symptoms following immunization, definitely you have to think of an adverse event following immunization, and definitely these symptoms can be are not directly related to the vaccination, but it is a coincidental event. Probably this baby might have had contact with other children having symptoms, so the baby might have exposed to a case during the immunization session, which we can infer from the history. And 2 days back, that is after 3 days of onset of symptoms, baby developed, mother felt that baby is having breathing difficulty. Baby had fast breathing, increased movement of chest wall, and noisy breathing as if there is sputum. Usually mother will say whenever there is a noisy breathing, she will say there is sputum. So that doesn't, you should not equate it with the sputum always. You should try to differentiate by taking the history in detail. And there is no significant difficulty in feeding. Inability to feed is a danger sign in any of the respiratory problems. Here there is no difficulty in breastfeeding. Mother felt baby was as active as before and not excessively sleepy. Excessive sleepiness or drowsiness is again a danger sign. And she felt that baby is more irritable than usual. And here have mentioned there is no history of diurnal or postural variation of symptoms. In bronchial asthma, usually you get a diurnal variation. The symptoms are more in the morning hours, early morning hours, or in the night hours. No history of cyanosis or seizures. So in severe cases of bronchiolitis, you can get cyanosis. In cardiac problems also you can have cyanosis. Seizures, in hypoxia, the baby can develop seizure or abnormal posturing, which is not there in this case. No history of excessive head sweating or suck rest suck cycle. So excessive head sweating and this suck rest suck cycle usually indicate congestive cardiac failure, and here there is no such history. So you can infer that the symptoms are less likely to be due to a cardiac problem. No history of diarrhea or vomiting. No history of choking or regurgitation of feeds. In infants, small infants, they may develop gastroesophageal reflux, which can lead on to aspiration and can lead on to respiratory symptoms. So frequent vomiting or regurgitation of feeds, that history is important. No history of weight loss or evening rise of temperature. Actually, in an infant like this, whether baby is gaining weight adequately is more important. And again, evening rise of temperature is not an important thing to be asked for in infants, and it is not a manifestation of tuberculosis in children. Probably in adults, you may ask regarding evening rise of temperature, but in children and especially in infants, there is no, this history is not at all relevant. No history of contact with COVID positive patients, so in this scenario that history is important. No history of foreign body aspiration. Foreign body aspiration can cause various types of respiratory manifestations, especially recurrent respiratory symptoms. And many a time you may get a history of aspiration, sometimes an elder sibling giving something to the baby. But in more than 50% of situations where aspiration of foreign body is foreign body aspiration is diagnosed, you won't get a definite history of aspiration. So if you have a history, it is important. Even otherwise, you have to suspect foreign body aspiration in such situations. No history of exposure to dust. There is no pets in the family. There is no history of, it is too early to say there is no allergy. Asthma, bronchial asthma is an important condition where infants or children coming with wheezing, usually you get recurrent episodes. So you have to think and ask certain details about allergy. In the past history of fever with cough 3 weeks back, and baby got admitted, treated with oxygen inhalation and parenteral medications and supportive treatment, and then discharged after 3 days. No history of nebulizations given. So this history is important. You have to ask more details about this illness, whether it is, one possibility is it could be a pneumonia, a child developing fever, cough and breathing difficulty, needing oxygen inhalation and parenteral medications. Most likely situation is pneumonia, and baby improved also. So another thing is baby again developing symptoms. So the same type of condition is recurring. One well-known example is bronchial asthma, recurrent episodes. And in this situation, as already mentioned, you have to ask more about the diurnal variations and also response to inhaled bronchodilators. Here there is no history of any inhaled medications given. And another possibility is baby might have had a foreign body aspiration, which can predispose for recurrent respiratory symptoms. All these you have to think when there is a past history. There is no history of allergies or atopy in the past, no history of fever with rash in the past, no history of aspiration in past. The usual situations of foreign body aspiration is during a seizure or related to feeding, or sometimes the elder siblings, they may give something to the baby orally. And no history of head sweating or feeding difficulty in the past. And in the antenatal history, is a second child of non-consanguineous marriage. Age of the mother at delivery was 28. In the first trimester, there is nothing relevant. Folic acid tablets were taken, 2 doses of TT taken. In the second trimester, quickening, no history of bleeding PV. Only thing is there is gestational hypertension in mother. And as mentioned earlier, this baby is an IUGR baby, only 2.25 kg it was mentioned. So the probable reason could be gestational hypertension. There is no gestational diabetes. Anomaly scan done was said to be normal. Iron and calcium tablets taken. Third trimester, again gestational hypertension on medication. Liquor was said to be adequate. In the natal and postnatal history, the full-term normal vaginal delivery, birth weight was 2.25 kg. So it is an IUGR baby. No history of NICU admission. Breastfeeding initiated immediately after birth. No other feeds given. Urine and meconium passed on first day itself, and baby was discharged on third day. So it's an antenatal or the postnatal period was uneventful. In the developmental history, gross motor development, head control 3 months, the baby is not able to sit with support. It's only 5-month-old baby, so it is normal. Fine motor by dexterous reach 5 months, and language, cooing and laughs allowed 4 months. No monosyllables. Social smile is there, recognize mother by 3 months, identifies familiar person in the family. There is no stranger anxiety. So the development is normal in this baby. Dietary history, it is an exclusively breastfed baby. So you have to inquire whether the breast milk is adequate or not, especially if the baby is not gaining weight as expected. So here mother has let down reflux. Baby feeds about 10 to 15 minutes per feed and comfortable for 3 to 4 hours after each feeds. passes urine 6 to 8 times a day. All this indicate that mother is having enough milk and baby is getting adequate breast milk. In the immunization history, baby is immunized till age as per the national schedule. As per national schedule. There are some immunizations which are not included in the national schedule, which are called as additional vaccines. You can inquire whether baby was given anything like that also. The baby was taken last vaccine just 8 days back, and the next vaccine to be given is MR vaccine at 9 months. There is no adverse events reported following immunization. The family history is a second child. History of asthma in maternal grandmother and maternal maternal aunt and paternal grandmother. History of similar episodes in history of similar episode in the sibling also. So here also you have to know history of tuberculosis in the family. And in the family tree or pedigree, if you shade a particular condition, here it is asthma, that means it is an inherited or a genetic problem. So all conditions where many members in a family are affected, you need not shade. So asthma is having a genetic component. There is no harm in shading for that condition. There is no history of tuberculosis in the family. In the socioeconomic history, father studied up to 10th and working as fisherman. Mother studied till 11th and she is a homemaker. It's a nuclear family, no overcrowding. So most of the respiratory infections, overcrowding has a definite role. Concrete house, it's near a paddy field. So near a paddy field, probably they're exposed to pollen. So the risk of allergy, asthma and all. A baby who is predisposed for asthma, the chance of developing exacerbations are more if there is a exposure to pollen and all. Firewood is used for cooking. So firewood also is a risk factor for various respiratory problems like pneumonia, asthma exacerbations. Father is a smoker, so smoking is a risk factor for both asthma exacerbation and also bronchiolitis. It can become more severe if exposed to smoke. The floor is tiled and they are sweeping the floor with the broom. So again, in conditions like asthma, you have to inquire all the details regarding the dust mite, whether the room is damp, whether they are having carpets in the room. So many details are important when you are suspecting asthma in the diagnosis. In general examination, the baby is alert and active, but irritable in between, and baby is lying in mother's lap. And the vitals, the pulse is 160 per minute, so there is it's a tachycardia, normal volume, all peripheral pulses felt equal on both sides. Respiratory rate is 58 per minute, so 58 is tachypnea for a child less than 2 months. Less than 2 months age, if it is more than 60 is considered as tachypnea. 2 months to 1 year, more than 50 is considered as tachypnea. 1 year to 5 year, more than 40 is considered as tachypnea. So here this is 2 months to 1 year age group. Here there is 58 is the respiratory rate, so there is tachypnea. Blood pressure is not mentioned here. Capillary filling time is less than 2 seconds, and SpO2 is 97% in right upper limb in room air. So SpO2 is normal here. in the anthropometry, the weight here is 6.6 kg. The expected weight or 50th centile here is 7.4 kg. But when considering the expected weight in a small infant, you have to consider the birth weight also. So here the birth weight is 2.25 kg. In the first 3 months there is 30 grams per kg weight gain, excluding the 10 days, the initial 10 days. So total of 80 days you can expect a 2.4 kg weight gain, and next 3 months you can expect 20 grams per day. So the 2 months means 60 days, so it will be 1.2 kg. So the expected weight you can calculate as 5.85 kg. So or roughly 6 kg is the expected weight. So this 6.6 kg is actually normal here. Length is again 64 centimeter, expected is 66, which is normal. Head circumference is 42, normal. Mid upper arm circumference 13 is slightly on the lower side, but not very important in a 5-month-old baby. You take the mid upper arm circumference only after 6 months of age. The head to foot examination, the head appears to be of normal size and shape, anterior fontanel open and normal tension, posterior fontanel closed. This anterior fontanel tension is important because you have mentioned that the baby is irritable. Posterior fontanel is closed, hair is normal, no facial dysmorphism, eyes normal, no flaring of nasal alley, ears normal set, no ear discharge. So you have to specifically look for an ear discharge because otitis media is common in it's a common upper respiratory infection, and it is always better to look for the tympanic membrane if you have an otoscope, because otitis media is an important association, and any child who is irritable having upper respiratory symptoms like nasal discharge, otitis media has to be ruled out, where you see red, the tympanic membrane in a reddish manner. Lips, gums and tongue normal, there is no cyanosis, no oral thrush or ulcers, no cleft palate or cleft lip. Cleft palate, sometimes a small cleft may not be detected in the newborn period. When the child develops frequent aspirations leading on to respiratory problems, then only you may diagnose a small cleft palate. Sometimes it may be a submucosal cleft. Submucosal cleft means the bony part of the palate, there will be a defect, but it is covered by the mucosa, so that on inspection you may not find the cleft, but on palpation you can easily identify the cleft palate. No features of atopic dermatitis. A baby where this baby had 2 episodes of respiratory symptoms. So one possibility we are considering is bronchial asthma, and the earliest manifestation of atopy is atopic dermatitis, where you can observe there is dryness or atopic lesions on the cheeks and all. So there is no features of atopic dermatitis. No pallor, icterus, cyanosis, clubbing. Skin and nails are normal, no features of atopic dermatitis. No redness or swelling at injection site. Baby had recent immunization, so you can look at the injection site. No visible swelling in neck. Chest wall normal. Increased work of breathing present. So increased work of breathing will be manifested as, one is flaring of alanacea. Flaring of alanacea. So what is the purpose of this flaring? So it is related to the airway resistance. So maximum airway resistance is in the larger airways like nasopharynx and trachea. You may not agree easily with that, but that it is related to the total cross-sectional area. So the cross-sectional area of the larger airways is less than the total cross-sectional area of the smaller area. If you consider the total cross-sectional area of all the bronchioles, that will be much more than that of the cross-sectional area of the trachea. So the resistance will be proportionately more in the larger airways. So a slight increase in the caliber will decrease the resistance markedly. So flaring of the alveoli will help in decreasing the airway resistance. So that is the advantage of having flaring in a baby who is having dyspnea. So other manifestation apart from flaring of alveoli, you can get retractions, chest retractions, it may be intercostal or lower chest retractions. So here there is increased work of breathing, no abdominal distension, external genitalia normal, spine normal. In the respiratory system examination, the upper respiratory tract, as mentioned, there is nasal discharge, which is mucoid, not yellowish or foul smelling. In most of the upper respiratory infections, initially the nasal discharge will be watery. Later on it becomes mucoid, then it becomes whitish or yellowish, and then it improves. So the yellow color to the nasal discharge doesn't mean that there is a bacterial infection. It is by the inflammatory cell infiltrates. Lot of inflammatory cells get infiltrated to the area of that area, and along with that the cellular debris. All these give the yellow color. So just by seeing a yellow nasal discharge, there is no indication to give an antibiotic. And foul smelling nasal discharge is usually seen in, especially if it is unilateral, you have to specifically think about a foreign body in the nose. The nasal, along with the nasal discharge, definitely baby will be having nasal block. And this nasal block can cause pain in the ears. So this baby is said to be irritable. One important reason for the irritability could be, one thing is because of the nasal block, there will be a pressure difference on the either side of the tympanic membrane, which can cause ear block. So if you instill saline nasal drops, this obstruction will be relieved, and there won't be the pressure difference will be corrected, and the baby becomes, that irritability or excess cry will be subsiding. So one easy way to assess whether the irritability or incessant cry is due to nasal block is by instilling the saline nasal drops in the nose and observe. And another reason could be the otitis media, where the middle ear infection, the pressure within the middle ear is high, and it is not going to be relieved by saline nasal drops. And another reason for irritability in this baby is the disease bronchiolitis itself. Many infants with bronchiolitis are irritable, could be due to mild hypoxia. So as mentioned, the ideally tympanic membrane also has to be examined. The lower respiratory tract infection, trachea is central. Shape of the chest, it is bilaterally symmetrical and normal. Chest wall movements comparable bilaterally. Expiratory phase is prolonged. So you have to observe the baby for some time, how the baby is breathing. In bronchial asthma and bronchiolitis, baby will take more time to breathe out and baby will be having difficulty during the expiratory phase. No intercostal indrawing or subcostal retraction. Skin over the chest wall is normal. Palpation, trachea is central. Apex beat is in the fourth left intercostal space, just outside midclavicular line, which is normal for an infant. Movement of the chest wall bilaterally symmetrical. It is very difficult to measure the expansion in an infant like this, which is not actually needed. You can observe whether the chest is expanding symmetrically on both sides. Tactile vocal fremitus is comparable bilaterally. Percussion, normal lung resonance on all areas bilaterally, and liver dullness percussed on 6th right intercostal space in midclavicular line. So, the liver dullness is pushed down. You expect it in the 5th space. In auscultation, vesicular breath sound with a prolonged expiration is heard. So, regarding vesicular breathing, there will be inspiration, there is no gap, and there is expiration, and rest of the expiratory phase is silent, and then again next inspiration, expiration. So, this is the normal pattern. So, if you draw like this, this is the inspiratory phase, this is the expiratory phase, which is almost equal, and you are hearing breath sounds only during the initial part of expiration. In bronchiolitis and bronchial asthma, what you expect is, this is expiration, inspiration, then this is expiration. So, the expiratory phase is prolonged. So, this is shorter than, so the expiratory phase is prolonged, and inspiration, expiration. So, the prolonged expiration, and you will hear the breath sound during for a more duration in expiration compared to the normal vesicular breath sound, where it is for a short period only. So, the expiratory phase is prolonged, and there is the breath sound, in the breath sound also there is a prolonged expiration. So, that is what you expect in small airway obstructions like acute bronchiolitis or bronchial asthma. And there is bilateral rhonchi, occasional crepitations heard over infrascapular and infraaxillary areas, and vocal resonance normal. And crepitations doesn't equate to pneumonia. In bronchiolitis also there will be increased secretions in the airways, which will give the sound of crepitations. CVS examination is essentially normal. Nervous system also normal. GIT, the liver is palpable 3 cm below the costal margin, which is soft and non-tender. You have to look for the liver span also. Here the liver span is normal. So, spleen is palpable 1 cm, which is soft. So, here the liver dullness is in the 6th space, and the liver is palpable also 3 cm. Span is normal. So, that means this is a push down liver, and the consistency of the liver again is normal. So, this is a normal liver which is pushed down because of the air trapping, which is expected in bronchiolitis. Spleen also can be palpable in bronchiolitis. So, summarizing, it's a 5-month-old male infant, term, low birth weight with a family history of bronchial asthma, exclusively breastfed, normal development, immunized adequately as per national schedule, and history of recent vaccination, and with a hospitalization for possible acute respiratory infection or pneumonia 3 weeks back. Now presenting with low grade fever, cough and cold for the past 5 days, and breathing difficulty for the last 2 days. There is no history of any danger signs. And the findings, baby is active, alert but irritable, mucoid nasal discharge, no ear discharge, fast breathing and increased work of breathing, expiratory phase is prolonged, push down liver, vesicular breathing with prolonged expiration, bilateral rhonchi and occasional crepitations heard bilaterally. So with this, the most probable diagnosis is acute bronchiolitis. The points favoring acute bronchiolitis, one is age group, typical symptoms. Typical symptoms means an otherwise normal child developing upper respiratory symptoms, low grade fever and cough, which is initially mild. After a few days, the cough worsens and there is dyspnea, wheezing, hyperinflation, push down liver, bilateral rhonchi and all. So there is typical symptoms and signs here. So the most important possibility will be acute bronchiolitis, and you have to consider some of the differential diagnosis also. One is bronchial asthma. So here this baby had similar symptoms 2 or 3 weeks back, and there is a total symptom free interval in between. So in asthma usually you have recurrent episodes with the symptom free intervals, but usually asthma is not diagnosed in infants, usually at an older age group, and again usually you get a diurnal variation. So here there is no diurnal variation, and there will be improvement with the inhaled bronchodilators. So that history also we are not getting here. The points favoring asthma are, apart from that, there is family history, exposure to allergens and irritants like cigarette smoke. Another possibility is pneumonia, and considering the previous episodes, it may be a recurrent pneumonia also. But in a child with pneumonia, with the fast breathing and dyspnea and all, usually the child will look very sick and child will have a toxic look. But here, despite this dyspnea, the baby is active and alert, which is one point against a bacterial pneumonia. And you are getting chest signs all over. In pneumonia, usually to have the signs in all the areas, you expect the child to be more sick. It could be foreign body aspiration, even though there is no history of aspiration, which is you may not get in all cases. A baby with recurrent symptoms, you have to suspect foreign body aspiration, or it may be gastroesophageal reflux also, which leads on to aspiration. So these are some of the differential diagnosis you have to consider here. Still, the most probable diagnosis will be acute bronchiolitis. Investigations, as mentioned in the initial part, to make the diagnosis of bronchiolitis, no investigations are needed. But since we have some of the differential diagnosis like foreign body and all, you have to take an X-ray chest. In this X-ray, there is both the AP view and lateral view. So you can count the ribs. The anterior part of the ribs, usually the fifth rib in the midclavicular line will correspond to the liver. Here it is the seventh rib, which shows there is hyperinflation. So that is the case of bronchiolitis. The management and all we have already discussed in the initial part.